Good morning, everyone. I want to welcome you to the last webinar of our 6-part series on opioids in the hospital, addressing inpatient harm. My name is Michelle Bonson, and I serve as a clinical quality consultant on the Compass HIIN team. For those of you on past webinars, welcome back. And for those of you joining for the first time, thanks for joining us today. The goal of this particular series is to provide participating hospitals with standardized and evidence-based approaches to reduce inpatient adverse events related to opioids. Today, we're going to focus on maintaining momentum with your work. We have a couple of brief housekeeping items to cover before we start our session this morning. We ask that you please take a moment and check your phone lines or computer audio and make sure you are muted. We appreciate your attention to this as it does help us avoid background noise during our session. We also ask if you need to step away during the session today, please avoid placing us on hold so we don't have your call waiting, background music playing during our webinar. We expect and encourage the questions as we move through the session today. Please use the chat box throughout the webinar to type in questions as they come to mind, or if you have some comments. If you haven't already done so, please set your chat to all attendees and panelists. This will allow us all on the line with you to see your comments and questions, and I will pause for a moment to make sure you all have it set accordingly. If you would like to speak during our webinar, please utilize the raise hand symbol and we will unmute your line to allow everyone to hear you. We realized during the last webinar that people couldn't engage in live dialogue due to using computer speakers rather than a phone line. So if you're able to, please dial in for the presentation. Dino or Lexi, would you be able to add the call-in information to the chat box? Thank you so much. So if that is a possibility for you, that would be great. If not, you can go ahead and continue to use the chat box. And I'll just pause for a moment here to allow us switch over from computer to phone and let Dino or Lexi get that call-in information put in. Thanks, Lexi. And as she puts that in there for you all, I'm just going to remind you that prior webinar recordings can be found on the Compass HIIN YouTube channel, and the location is noted in the footer of this slide. Before we get things underway, let's take a few minutes to go over the agenda. And actually, before I do that, I just want to remind everyone that you did receive an email with a link to today's presentation. And if you, and somebody just posted in the chat box, if you would like to access the slides for this webinar, was from Dino, please follow the link. So let's go over the agenda now. We will do a quick intro to see who's on the call, go over a few announcements. We'll briefly recap webinar 5, talk about some key factors relative to maintaining momentum with your QI projects, and review opportunities for ongoing improvement with your opioid harm reduction work. Before we close out our time, I will host a focused Q&A session with our pharmacist, Matt Pitlick, who IHC is very fortunate to have on staff. And when we get into that portion of the presentation, I will have Matt introduce himself. And before I bid you all farewell, I will talk about next steps for this series and then have Sandy Atkinson join us to share details regarding the next Jumpstart series. All right, looks like we've got the phone numbers in there. We've got the link to the slide deck, so we're ready to go here. Let's find out who's on the webinar with us today. Please take a few moments to type your name, organization, and role or title. And then our little icebreaker today is to include your first job. And I bet many of you can guess by what I put in there by way of food, where I possibly worked for my first job. I want you to kind of think about then to now and what it took for you to get from there to here. I would venture to guess it took commitment, opportunity, possibly some sacrifices, diligence, passion. I'm sure that there are many terms that could be inserted there. Even back in my days of working under the golden arches, there was never-ending process improvement opportunities. And when changes did happen, we needed to be ready for the next best way of doing a task or promoting a new menu item. Momentum is what keeps organizations moving forward to be the best they can be, and ultimately set stretch goals, and execute on their strategies. So feel free to share a couple of thoughts relative to your first job or your job today and where maintaining momentum has come into play. I like what I'm seeing in the chat box. Thank you everyone for sharing. And looks like a lot of people's first job was in the healthcare industry, which is fantastic. Yeah, I was pretty much flipping burgers from age 16 to about 19. So McDonald's was a great place to work if you were involved in a lot of school activities. And Tanya, you have people with you, Nicole, Elizabeth, and Delilah. I don't know if Tanya's actually on, but oh, cool. Parks and Rec. Oh, I remember going to Parks and Rec. Oh my gosh, actually, Stacy, I need to back up. I had a paper route too. I completely forgot about that. I think there's a reason for that. I really didn't enjoy that job, quite honestly. Okay, I digress. I'm sorry. I like to have a little icebreaker because I can't be in the room with all of you. Where have the last 7 weeks gone? Can you believe that when we all first came together, it was actually the first week of June? My hope for you all is that you took something of value away from the time you spent with me and your peers. Based on feedback received from several of you at the halfway point, there was an appreciation for increased knowledge on inpatient safety relative to opioid prescribing and use. Some of you were taking a deep dive into your policies and or procedures. Some were thinking about what they might be able to do first as a result of their internal findings when stacked up against best practices. Regardless of the level you're at or where you are focused, I want you to know that I've really appreciated your time and commitment. During the 5th webinar of the series last week, we did a quick pulse check with all attendees to see what types of learning opportunities, goals, and possible ideas on what may be implemented in the short to long term to avert or decrease opioid-related adverse events at your hospital. Following that, we spoke to key strategies relative to specific interventions and how to both implement and evaluate them. Some of these included embedded risk analysis within the EMR and or during the admission intake. This was balanced by emphasizing the importance of following up on assessed risk via use of a pharmacy consult, standard and specific monitoring, and documentation protocols. We also discussed the importance of working with your internal stakeholders to create processes that are standardized and simple in order to increase compliance and adherence. Finally, we closed by discussing the importance of every QI project is to start, just start. Set aims and a timeline in which you expect to meet and accomplish things, accomplish what you set out to do, and of course, measure, report back, stay the course, and celebrate successes along the way. Are there any comments or questions before we get started on this week's content? Okay, I'm not seeing anything, so we will just go ahead and move forward. During our introductions today, we've discussed momentum as it relates to change and goals and new or better ways of doing things. In other words, there never seems to be a shortage of quality and process improvement opportunities. Once you have a solid process and you roll it out, you then need to monitor it to make sure that you're still on track, that you're still in alignment with best practices, and begin to look at opportunities to enhance and complement what you've implemented. In other words, you need to sustain and spread. There are a few signs that suggest a QI project is ready to be sustained. You should be able to answer yes to the list of items on the slide in front of you, as they would suggest sustainability is in sight. A couple of things I'd like to add. When testing changes with staff, make sure you include a feedback loop. Infrastructure should include people, supplies, equipment, tools, technology, education, culture, leadership. Performance reporting should be displayed in a format that succinctly tells the story, and consideration should be given to the level of detail depending on the audience. Sustainability does not equal stop. Momentum should be maintained beyond the life of a project to ensure that process improvements are maintained. This visual put out by ARC demonstrates the value of checkpoints to assure identified gaps are closed. How do you see, or how have you seen other projects sustained in your hospital? Using the chat box, let us know some of your keys to success. And great, ownership, absolutely. If there's no ownership, it's kind of like who's going to do it, right? There's some accountability there. I'll throw out a couple of ideas while I wait for some additional comments. Early identification of barriers and possible solutions. Engaging your senior leaders and champions early in the process. There's nothing worse than getting down the road and then forgetting to engage people that can really help create additional momentum. Leverage the innovators, early adopters, and early majority. So those are the people that are curious, interested, looking for ways to improve, and are going to sort of be on board with you early in the game. And then use of patient and family stories that drive home important lessons. I think that's something we always need to remember, whether you actually have a PFAC or you have patients and families engaged in some level of safety or quality at your hospital. Maybe it's something that came in from a survey of sorts, or perhaps even just something that happened. If you use patient and family stories, we can all understand that. We can all sort of assimilate to that, and it really helps us understand why we're doing what we're doing. It makes it real. According to ARC, sustainability is the process of embedding a successful improvement into the culture and norms of a facility or unit, while SPREAD is implementing a successful improvement process across multiple units or facilities. In other words, you take what works in your test and then you spread it to the larger population that will be utilizing the process. I think it's important to keep in mind that what worked in one area or environment may not work in another. And as such, spread efforts will benefit from the continued use of the PDSA cycle. Units adopting the change need to plan how to best adapt to the change in their unit and to determine if the change resulted in the desired and predicted improvement. Spread requires as much planning as your testing and implementation phases. A spread plan helps ensure that the process, feedback, and next steps are documented. Here are the basic components of a spread plan and their suggested order of use. Organizations are encouraged to add components to address their needs and revisit the plan throughout the spread's progression. A spread plan should involve strong communication among the team, collaboration with other units, perhaps selecting similar units or areas in which to spread the process is often a successful strategy. Accounting for variability, you will more than likely encounter variability. So it's important to first develop a process that benefits the majority of patients and then work to identify and incorporate the variability of patient populations and clinical considerations. Keep in mind that variability does not consider staff preferences. I think that's something that we always need to remember. Identify units able to adopt the process easily. And units that are outliers, those units that maybe need to alter the steps of the process significantly, should probably wait to put the new process in place so they can benefit from the data collected and the lessons learned by the units that adopted the process earlier. I need to apologize to all of you up front. There were some technical difficulties I experienced during a test run of the presentation this morning, so I'm not able to show you this fantastic video clip that was put out by ARC in support of factors that affect spread. This particular vignette is a great example of how leadership was engaged, teams shared wins, barriers were discussed, and solutions were identified. It's focused on ADEs, and as such, it's obviously quite fitting to our Jumpstart series. The entire video is about 6 minutes in length, and I decided to keep it in the deck as I would like you to view this outside of our time together. I would encourage reviewing it with your entire quality team. The link to the video is embedded in the footer of the slide, so you should be able to access it very easily. And again, my apologies. I really wanted to show it, but I just didn't think it was going to work out so well. We've discussed sustainability and spread. Are there any questions or comments before we move forward with some ideas for additional enhancements or opportunities to complement your work to decrease opioid harms? I'll pause for a moment here, see if anything comes in the chat box or any hands are raised. Okay, I'm not seeing anything right now, so we'll keep moving along here. Talk a little bit about opportunities. So the period following discharge from the hospital is a vulnerable time for patients because they have not fully recovered from the event that resulted in them seeking services. Many times they require some form of ongoing acute care, typically they do. Medication complications after discharge are common. Approximately 1 in every 5 patients suffer an adverse event after discharge from the hospital, and most of these are related to the inappropriate use of medication. The Society for Hospital Medicine cites that effective and safe transitions of care include detailed communication regarding medical management in the hospital and out of the hospital. The patient and family should be able to name and know how to contact the clinician who will manage any post-hospitalization pain. They will be the ones who will prescribe opioids or other analgesics, and this clinician must be identified prior to discharge. A complete medication reconciliation of all medications should be done. There should be education on safe disposal of medications, signs and symptoms of adverse events, and what to do in the event of a serious adverse event. The patient should be included in decisions regarding post-discharge comfort and goals to increase function. Include counseling on the use of alcohol and other CNS depressants. We know what happens when those are combined with opioids. A discharge follow-up appointment should be scheduled prior to departure with the provider prescribing opioids after discharge. Let me state that again. So a discharge follow-up appointment should be scheduled prior to that patient's departure, and it should be made with the provider prescribing opioids after discharge, as this is where tapering should be managed if a tapering plan was not already put into place prior to leaving the hospital. Based on research, this discharge follow-up appointment has also been found to positively impact readmissions. And all of you who have been part of the HIIN for some time now know that we work really hard on readmissions. And one of the process measures that you sometimes choose is that discharge follow-up appointment. And it's equally as important in this scenario as well. I touched on tapering just briefly. We're going to talk a little bit more about tapering when we bring Matt into the discussion. And I would like to point out that many of the goals and approaches set forth by the Society for Hospital Medicine are included in the IHC Comfort Treatment Plan. It's here up on your slide, and a link to the tool is included at the bottom of the slide for your reference. In May, I had the pleasure of listening to a couple of presentations during a CMS pacing event. And this particular event highlighted 2 health systems' opioid stewardship efforts. I would like to share a high-level overview of each of them, and then I strongly encourage you to listen to the recorded version of the presentation and download the associated PDFs. Links are included in the reference slide of today's presentation. I guarantee you won't be disappointed, as each organization took very practical and strategic approaches to their work. The entire presentation, including both hospitals, is about 1 hour in length, so not too long. The first hospital to present was Blessing Hospital, located in Quincy, Illinois. They had a really robust antimicrobial stewardship program and thought to themselves, wow, we could really leverage and transfer best practices to our opioid stewardship work. Each of them, as you know, if you're implemented an ASP and maybe you're looking at an opioid stewardship program, each requires leadership support, medical staff education and commitment, tools and hardwired processes, including surveillance reports, and inclusion of a pharmacist in their multidisciplinary work. So off they marched, only to encounter a new opioid crisis, a shortage of injectable opioids due to manufacturing problems, and I think that was right around 2018. They had an immediate need for information on inpatient IV opioid utilization, so they formed a multidisciplinary task force and put into place some fairly aggressive changes, which included immediate removal of IV opioids from all order sets, widespread education on non-opioid analgesia, including new order sets that promoted increased use of IV acetaminophen and Toradol, and increased use of non-pharmaceutical relief, which included massage, aromatherapy, and a pain resource nurse. They limited the duration of IV opioids to 24 hours, and this was an effort to preserve supply to their OR, PACU, ICU, and their hospice area. They monitored use in daily stewardship rounds, which included a decision support tool with feedback to providers on opportunities to move from IV to PO or to alternate agents. Some major successes they achieved and still are in place today, from my understanding, include community education. They use social media and local news channels to discuss their efforts and their plan and a commitment to their patients' comfort, which I thought was absolutely fantastic. Upfront with the information, letting people know what they could expect, engaging them in their care, explaining the situation. And procedures historically using fentanyl were performed with reduced or no opioids. So for example, cataracts, cardiac cath, bronchs, and alternative routes and types of medication were successfully used in select procedures and in both pre-op and PACU. The second hospital to present was Virginia Mason Medical Center, located in Seattle, Washington. And I just have to say, and I'm trying not to pick favorites here, this is a presentation that you will want to really dial into. I would suggest not multitasking, listening and then listening again to jot down some key notes. This is an organization that has been at work honing and refining their work in this area since 2016. Their efforts demonstrate they are patient-focused, and they execute and evaluate across their care improvement continuum. Some of their key investments have been educational offerings and creating protocols and pathways for both opioid naive and opioid familiar patients. They are never short of ideas or focus, as evidenced by their interspersed visioning exercises, which lead to motivating views of the future. Patients remain at the center of care as they think about what to do with them and not to them. Again, I highly encourage, if you have an opportunity, to listen to both of these. They are really fantastic. I think it goes without saying that pharmacy involvement is another priority opportunity. So without further ado, I would like to ask Matt Pitlick to join the discussion so we can talk about the pharmacist role relative to opioid safety in your hospitals. Matt, why don't you go ahead and take a moment to introduce yourself, and then we can get into some questions I have for you.
Sounds good. Thank you, Michelle, for that lovely introduction. And talking about pharmacy in the hospital and their role in opioid management. But first of all, yes, like Michelle said, I am new to the Iowa Healthcare Collaborative team. I began on July 1st, so about 2 weeks ago now. So looking forward to getting started and getting involved in all the things that are going on, especially in the opioid realm. and continuing the work that Sarah Durr had moved forward over the last couple of years. Excuse me.
Great. Thanks, Matt. For those of you on the call today, please feel free to enter your comments or questions in the chat box, and we'll do our best to make time at the end to address them. So, Matt, if you're ready, I think we can go ahead and get started with some questions that I have for you.
Yes, absolutely.
Awesome. So, where do you see pharmacists participating in the management of hospitalized patients who are prescribed opioids?
Yes, very good. Well, it should hopefully be in all aspects of opioid prescribing. Really from the time of entrance into the hospital, doing a medication reconciliation to see if that patient, what medications that patient is taking and how they're taking them and what they're taking them for. And then additionally, when the physician is prescribing or is utilizing those medications, which ones the hospital has, needs, and also monitoring for those as well. And also at discharge, when the patient is discharged, making sure that a med rec is done at that time of discharge, and also educating that patient or family at the time of discharge as well.
Great, thank you so much. So what barriers exist today relative to including a pharmacist in the oversight of prescribing opioids? And what are your thoughts around breaking down those barriers?
Sure, so there's a few different things. A lot of times it can be communication, so communication problems, whether it be with the nurse, the physician, the hospital team. Making sure that pharmacist is involved in those decisions can be very important. And it's not necessarily anybody's fault in those situations, it's just the culture of the hospital or the time, or maybe there's only one pharmacist on the team that can help out, and that pharmacist's time is distributed in different ways. Other things that can be going on too, so the pharmacist will have to be involved in other things besides opioid management as well. So working on drug shortages or high cost medications like you talked about earlier.
From your perspective, I'm going to change directions here a little bit. How important is it to differentiate between chronic pain and acute pain?
Sure, that's a very, very important piece of information. It's kind of one of the hot button topics right now. In the media, if you see, a lot of people are putting the CDC guidelines under attack for limiting opioid use for especially for chronic patients. Those patients have been put under the radar. Those patients do need some sort of opioid management for that chronic pain, but you'll see in the media that news going back and forth. And so right now it's very important to really look at the difference between chronic and acute pain. Oftentimes it's hard to differentiate that in the hospital because the patient is coming in because of some sort of acute pain, or what you're seeing in the hospital is an acute pain issue. And it's very, very important to differentiate that. So as long as you have a good comfort scale, good education for patients, education for providers and nurses and all the hospital staff, that's very, very important. That also helps to determine whether that patient might need some sort of education or referral for opioid use disorder, substance use disorder, or communication to that patient, the patient's primary care team at time of discharge.
I think that really emphasizes a lot of the things that we've talked about in our earlier webinars, Matt. Thank you. We spent some time talking about how you can't just de-escalate those patients that have chronic pain and maybe are coming in with opioid use. They're opioid familiar, and so there's just different ways that we have to make sure that we manage and not de-escalate too quickly. So thank you for that.
Absolutely.
You bet. How can the pharmacist help promote alternative therapies or non-pharmacologic approaches to pain?
Sure. So your pharmacist should have the knowledge of all or most medications out there. It's hard to keep up on everything as new things come out every day, but your pharmacist should have that knowledge. And if not, we can find where where we need to go to find that information, whether it be something over the counter to recommend at the time of discharge, or really a Tylenol or acetaminophen, ibuprofen, nonsteroidal, something of those types of medications for pain. And we kind of also ask ourselves, is an opioid truly needed in this area? And if not, maybe we can suggest an alternative. Additionally, there are quite a few non-pharmacologic, non-medication routes for pain management that pharmacists do get educated about in school and continually, especially now with all the education out there now about pain management, whether it be chiropractic, which CMS is considering covering, physical therapy, heat and ice, all those sorts of things that we talked about, aromatherapy, like you talked about with the at the Virginia Mason Hospital or the Blessing Hospital, that was doing some of those really cool, non-pharmacologic methods for pain management.
How can the pharmacist assist with assessing the use of rescue naloxone in the inpatient setting? In our HIIN data, we've seen increased use of rescue naloxone in the inpatient setting, and thus the premise for sort of having this jump start in addition to just education. So how do you see the pharmacist assisting with that, and what are some of the unique perspectives they may be able to bring when they look at risk as a whole or at an individual level? It might be a medication error, prescribing practices, et cetera. So that's kind of a loaded question. If you need me to break it down, I'll be happy to do so.
That's okay. No, it's okay. I would say first, if you have an opioid management team or a opioid stewardship team at your hospital, and a pharmacist is not included on that, please start including them on the team, or at least consulting with them as things move forward, because your pharmacist can bring a unique perspective in terms of it's not just when an opioid prescribed that a naloxone is needed or is used on the rescue side, especially on your internal medicine floors. But they can think about which medication is prescribed, because all your opioids have different levels of potency. They know which ones are on drug shortage, which ones aren't. How much medication is being used at certain times. Maybe it's a certain provider that's really prescribing a certain amount or a certain type of opioid that is needed. Maybe you can look at different order sets of when a certain morphine milligram equivalent is prescribed, that a naloxone is sent to the floor, or naloxone is available for those patients, or all different types of communication within that.
So having said that, and we're fortunate to have you here, and some of our hospitals are fortunate to have a pharmacist on staff, but what are your thoughts about engaging a pharmacist when a hospital may not have one on staff, either at all or maybe even only part-time?
Yeah, it's a great question. Of course, this is one of a very important topic, because a lot of hospitals, it's either part-time or you have one pharmacist, and that one pharmacist is doing so many different things that their time is spread thin, and can't get to the floor all the time to help with certain questions. But if you have a part-time pharmacist, it's really utilizing that pharmacist to the maximum capability for whatever your hospital's top priorities are. And if you're on this call, I'm assuming that opioid use is the top priority. So making sure that that pharmacist is involved in all those different aspects of opioid use and prescribing and education within the hospital, whether it be with patients, of course, education, family education, provider education, whole hospital staff education, but really utilizing them to that maximum capability. If you have maybe a contract with another pharmacy to do things on the weekends, if that pharmacist isn't there, really having them hone in on those top priorities as well is very important. And if you don't have a pharmacist or a relationship with a pharmacist yet, I'd really highly encourage you to utilize your local community pharmacist if you have one in the area. I believe 98 of 99 counties in Iowa do. So if you're in that one, I hope we get one soon. But really develop that relationship with the local community pharmacist. They might be able to help you with medication reconciliation if that's an issue, communication to the primary care provider, or whoever is providing opioid prescribing for that patient. Maybe it's something you can do on a consultant basis with that pharmacist to help maybe come in, do that med rec one day a week, or whenever the majority of patients maybe get discharged from your hospital, those sorts of things. But even just a call, have a line of communication open with your community pharmacist can be a world-changing, life-changing event maybe for a patient. You never know if that line of communication is open.
Thanks. I know I mentioned tapering a little bit earlier in the presentation, and For those of you that came to our annual forum, we had a speaker by the name of Travis Reeder, who actually, I think his book was just published, but he is a person who experienced, I think, a severe accident and extreme pain and multiple surgeries, and really didn't know what to expect with his opioid treatment plan. And not only that, he was not put on a tapering plan. So could you just explain the process of tapering and why it should be addressed in advance of the patient being discharged from the acute hospitalization?
Sure, of course. So tapering, I think we all pretty much know tapering is slowly, gradually decreasing the dose of a medication until that medication is no longer being taken, or whatever the treatment plan is decided to. And it's hugely important, especially on the inpatient side now, to make sure that patient gets the lowest dose for the shortest amount of time, to make sure there's no, one, adverse drug events, or two, which acute use of opioids turns into chronic use of opioids. I just read a paper. It's not even a paper. This is a presentation. This is out of the American Society of Health System Pharmacists, ASHP is who that group is, that one opioid prescription can trigger long-term dependence and addiction. And the risk for chronic opioid use increases with each additional day of opioid medications starting after the third day. So after 3 days of taking an opioid medication was when the risk for chronic opioid use started. And the biggest increase in chronic opioid use occurred after the 5th day and after the 31st day of use, or on a second prescription or refill. So if we get this process started in the hospital, this really could prevent so many folks from going from acute use to chronic use, as you can see there. So if you can limit it to a couple days, and if then necessary, the shortest amount of time possible, that can be hugely, hugely important. And not only that, but also the education piece that comes along with that. So talking about these things with those patients, I think, is important as well, and their families.
Absolutely. When do you think patients are most vulnerable or have the greatest risk of experiencing an opioid-related adverse drug event during their hospital stay? And what are a couple things that might reduce or eradicate such events from your perspective?
Sure. So what I say is probably cliche, but those patients who are on multiple medications, have multiple chronic diseases, and elderly tend to be those patients that you will have an opioid-related drug event or adverse event within a hospital stay. And that's not uncommon for any other sort of adverse drug event that may happen. Those patients that are multiple meds, multiple chronic diseases, things that are competing for different receptors and elimination within the body tend to have a higher incidence of adverse drug events. And in terms of things that might reduce those adverse events, medication reconciliation and review, comprehensive medication review, I think is the most important thing. That way, we can identify if there are drug interactions, which drug interactions are going to be important, which ones may not be all that important, which is important to know as well. And then how long those patients been taking. Maybe that patient came in on hydrocodone or oxycodone. We can find out how long they've been taking it, whether they've been taking it for, that sort of stuff. So really, this complete medication review can be hugely, hugely important at this time. In the future, I think the one thing that will be very important, and not in a too distant future, we've been talking about it for a while, but it's pharmacogenomics, and we can tell from a patient's genome sequence which opioid, if needed, would be the best for them to take based on their genetic response to hydromorphone, fentanyl, hydrocodone, etc.
That'll be interesting, Matt.
Yeah, it definitely will be.
How that unfolds. How important is it to consider health literacy and the use of teach-back for patients who are prescribed opioids? And from your perspective, what are some best practices relative to patient family engagement? So that's kind of two-part, because we talk about health literacy, we talk about teach-back, but then it's also about the engagement piece.
Absolutely. So health literacy, of course, is extremely important, and we know health literate patients take their medications better. They do better while taking their medications versus patients that are not health literate. But the hard thing about in the hospital, right, from discharge from being discharged from the hospital, the patient has so many things going through their mind right now, right? They're newly diagnosed, maybe with a new condition, or worried that whatever brought them into the hospital is going to bring them back in a few days. So it's hugely important. So the education piece, I think, is a really hard thing to do on the inpatient side. So as much as we can engage the family in that education piece is going to be important, and also making sure to ensure that they have some sort of follow-up, like you mentioned before, Michelle, in a couple slides ago, where you were talking about making sure that an appointment is identified and already ready to go for that patient prior to discharge. Is such a huge important thing, because we've seen the one education time slot isn't enough for patients and families to get all the information that they need. They need multiple times to be educated about whatever condition, in this case opioids, to make sure that patient is knowledgeable within that of the realm of healthcare that we're talking about, whatever it may be. And also in terms, maybe it's just something that's fairly easy. Maybe we do get a tapering scheduled down for that patient, and they need 2 days of medication, but they didn't really get it all. So as much as that teach back is good, but also communicating that to the community pharmacist who that patient goes to, or to the provider who that follow-up appointment is with, is going to be hugely important. Or maybe it's something that is, could be life and death, such as an naloxone, a prescription that patient needs. You have to engage the family in those certain things and make sure the family understands exactly what the medication is for, how it's used, etc.
Perfect. So we've covered a lot. Is there anything in particular that we haven't covered that you'd like to add before we open it up to some questions from the participants?
Sure. No, I think we covered quite a bit in a short amount of time. But I would just say, it's all about part of the team. Pharmacists just want to help and want to be part of the team. So as much as you can utilize your pharmacists in your hospitals, I think the better the patients will be, and two, the other providers that have a lot of burden placed on them and a lot of responsibility placed on them, especially in terms of opioid use and metrics and monitoring and quality. I think the better lives everybody will have.
Thank you so much. I think we'll take some time now and make sure that if you want to enter a question for Matt or a comment into the chat box, that you have it set to all panelists and attendees. Or if you would like to actually be unmuted and speak, we're happy to do that too. Just go ahead and feel free to throw things out. Oh, we've got Sandy.
And I know there's at least one other pharmacist on here as well. I saw Naomi.
Oh, there is.
So Naomi,
okay.
Yes. Naomi, feel free to jump in.
It looks like Sandy said opioid step-down plans can be difficult to implement. Any suggestions on how to get this started?
Yeah, so depending on what type of opioid step-down plan we're talking about, of course, if it's an acute situation, can be a little easier than if it was a chronic type of opioid prescription, opioid pain patient. So I think, acutely, it's fairly simple. You start at your dose and move your way down, and that patient shouldn't have any big idea as to how long it should take. You tell them to take it a certain amount of time, they should be able to do that. Much like a steroid prescription, something like that. As far as chronic pain patients, this can be a little bit more difficult, of course. A good time to start asking the patient and going through the steps to get the patient ready for it, the readiness to make any sort of change, really getting the patient educated about the benefits of decreasing their opioid medication load. The hospital can be a good place to start that talk. It's hard to implement that, but then talking with the providers, primary care providers or community pharmacists to help with any suggestions there, I think that can be helpful in continuing the message for those patients who maybe are resistant to decreasing their opioid dose for whatever reason.
Great, thanks. Anybody else have any questions for Matt? Comments? We'll just give it a second here. Sometimes it takes a little time to type in the chat box. And if you don't have any questions, that's fine too. Matt is here on staff with us now, so we'll be able to, oh, there's Naomi.
There we go.
Yeah. Okay, so hi Matt, I'm grateful for Michelle's reminders on looking for feedback. Our nurses have stopped using the comfort menu and need reminders. Yes.
Thanks, Naomi.
Yeah, it's one of those things that kind of goes along with sustainability, right? Kind of evaluating, are things still being used? If they're not being used, why are they not being used? And just kind of refocusing people. When I shared about Virginia Mason and their visioning, it was really interesting. And I kind of keep picking them out as a favorite, and I apologize, I don't intend to, but their visioning piece was really important because as you all know, as we work on things within our organizations, no matter what type of organization you're in, sometimes things just kind of start to fall off and think about, oh, nobody's looking, or that's not important anymore, or I don't have time for that. And so the visioning helped them sort of reassess along the way, what did they want to be? What did they want to look like? What was important to them as an organization? And it kind of offered an opportunity for everybody to come together and kind of get back on the bandwagon with all of that. So it was really great. All right, I don't see any other questions. As always, I just want to remind all of you that if you do have questions after this, and you would like to send them to me in an email or send to Matt in an email, you can see that his email's here. We are available to help. Just because this jumpstart is coming to an end today doesn't mean that we won't have ongoing work in this area. So thanks, Matt. I really appreciate it. And if there are any other questions that come in before we end, we'll be sure to try and address them, okay?
Yes, thank you. Looking forward to working with everybody in the future.
Great, thank you. So as you noted, there are some footers in the slides that I put so you can actually access the references that I used. But in addition to those, here are some references for today's webinar. And the number 3 there on the list is the one that actually is the presentation on blessing in Virginia Mason. And the first one will take you to the presentation, and the second one will take you to the PDF. As we bring this session to a close, I want you to know it has really been my pleasure to spend time with you on this very important topic. We will send out a follow-up email that will include a link to today's presentation. In addition, you will receive a separate email with a short survey regarding this jumpstart, and your responses are really valued. I want you to know that, and they help us improve our selection and delivery of education and materials. And before I let you go today, if I had a drum roll, I would do it. I would like to ask Sandy Atkinson to join us to introduce herself and provide you with an overview of the next Jumpstart series. Sandy, are you on?
I am on, Michelle. Thanks so much. Hi, everybody. I am Sandy Atkinson. I am the newest, if you will, clinical quality consultant with Iowa Healthcare Collaborative. I've been here about 4 months. Prior to that, I was a director of quality and patient experience at a rural hospital. And so I just wanted to invite all of you to attend our next Jumpstart. It will be on healthcare acquired infections. And I know that topic is huge, and we could cover just about everything under the sun and throw in the kitchen sink. But there's 3 particular topics that I'll be focusing on. The first one is ventilator-associated events. And I know a lot of facilities don't have ventilators, but I feel that some of the best practices that will be shared in that will be applicable to everybody, so I would encourage you to attend. With that one, I would like to see infection prevention, quality, and respiratory therapy on that session, just because I think there's great feedback and discussion of best practices that can happen for everybody that would be instrumental. The next topic is on C. diff, also known as Clostridium difficile, or as NHSN has now taken to calling it Clostridioides difficile. It took me some practice to learn how to say that. We'll be talking about community versus healthcare acquired, best practices for surveillance and prevalence. And with this one, I would like to encourage you to not only have quality and infection prevention and nursing, but also consider having your EVS staff involved in this, because EVS staff plays a huge role in preventing this disease from spreading. And then the last topic is going to be on sepsis. And while that's a huge topic, I'm going to talk about the metrics as they apply to the HIIN, talking about post-op sepsis, the 3-hour bundle, the 6-hour bundle. And I would just like to get some sharing of best practices. I know with some of my facilities that I've worked with, they're struggling with the whole fluid resuscitation piece when it comes to providers adhering to that. So I would like to hear how other facilities are dealing with that roadblock and just share some of those things. And with that one, infection prevention, quality, nursing, ED staff would be pertinent to be in this one, because most of these septic patients don't present at the clinic. They present at the ED when they've been in crisis. And it's really important to get those bundles started. So this series will run from October 16th to November 20th. We'll close it up just right before Thanksgiving. So I hope to see everybody on.
Thank you, Sandy. It's going to be a great set of opportunities. And I really like that you can select 1, 2, or all topics. Of course, we'd like everybody to do all of them, but I like the flexibility in this schedule. And I just look forward to it. It's always interesting to participate in all of your peers' activities and see all the great work that's going on. If you have any questions about any of our jump starts, please feel free to reach out to your clinical quality consultant for assistance. We're happy to help you. And on behalf of the entire Compass HIIN team, I would like to thank you for putting quality and safety first in your hospitals. And I wish you all a wonderful remainder of your summer. Bye, everyone.